level. She's working, she has a working experience of total 17 years in pediatric department. She has done oral research presentations here itself in an Igrim's hospital on quality improvement initiative. She is a member of TNI. So thank you so much. Sister has done our presentations before also. I think many of the participants already know, but this is for those who have joined late. Okay. So today we have a guest speaker, Dr. Rosina Madam. Madam is working as an assistant professor in Department of Pediatric, Nigrims. Ma'am has done her MBBS from LHMC, University of Delhi, and passed out in the year 2008. Ma'am has done a pediatric MD in pediatric from the IGMC Hospital, Himachal University in the year 2013. She has worked as a senior resident doctor from VMMC, Safdarjung Hospital, New Delhi, and also worked as a senior resident in Nigrims Hospital. She is also a research scientist in Nigrims Hospital itself, and past 2019, she is working as assistant professor. She is also working as a clinical fellow in Anurian Bevan University, Talbot, Wales, UK. During her career, she has done 5 publications and done a presentations 8 in research. She is she is a member of various associations like Indian Academy of Pediatric, IEP Palliative Care, IEP Pediatric Critical Care, National Neonatalism Forum of India. Currently, apart from her regular job, she is also working under 5 different projects. So thank you, ma'am, for accepting our invitations.
Thank you for a kind introduction.
So now we will start our today's sessions. As usual, we will do the presentation first, then at the end, we will do the discussions. Okay. Now I will hand over the forum to our presenter. Okay, over to you.
Thank you, Nanuka, for the introduction once again. And I welcome and good afternoon to all the participants and ma'am and everyone. And I welcome all of you to this afternoon session again. And I also would like to take this opportunity to say thank you to Ma'am Rosina and of course Sir Himesh Burman, who is not here right now, for their constant support to us, especially to the nurses in pediatric department. On behalf of all of us, I say thank you for guiding us in many ways, be it research or presentation. If they are not there, I think today we might not be sitting here and presenting. Because of their constant support, we are here. So once again, thank you, ma'am. So like for today's session is on management of MISC. And before we proceed to the MISC, we just want to know how many of us know what is MISC here. You can write in the chat box whether it is a new or like whether you know or not.
You can write down in the chat box if you have heard about MISC. Okay. Thank you. No need to mention previous submitted, please. Okay, it's a new to me. Okay, new. Okay, so for many of the, okay, totally new. Thank you so much. That is,
I think many of us, for many of us, it's new, and then I won't go for the full form of MISC. I was thinking I'll ask about what is the full form of MISC, but since it is new for many of us, I will not ask for that. We will go to the next slide on management of MISC. We'll discuss on that. Next, Nanko, it's not going with this. Okay, so the objectives here are we will go with the introduction of MISC and definition and risk factor of MISC in children and diagnosis and then management of MISC in children. So with this objective, next slide. So here in introduction, MISC stands for multi-system inflammatory syndrome in children. It is also known as PIMS, that is pediatric inflammatory multi-system syndrome associated with COVID-19. And it is the youngest diagnosis and first reported in one of the youngest diagnoses and first reported in UK, US in April 2020 after post-COVID infection in affected population. And it is hyperinflammatory syndrome, which involves multiple organs and requires urgent and timely treatment. So MISC is uncommon and rare serious conditions seen in children and adolescents in between 0 to 19 years of age, and latest it goes to 21 years, I think. And then it is reported 2 to 6 weeks after COVID-19 infection, and it involves multiple organs like skin, heart, lungs, the kidneys, GI. Here it become inflamed, and which require timely diagnosis and treatment, and is associated with good outcomes. And the risk factor of MISC are like 0 to 19 years of age and previously affected with COVID-19 and exposed with COVID-19. And after this risk factor, we will be going with the clinical symptoms. Before we, can you please list the symptoms of signs and symptoms of MISC? If any of us knows about it, like, can we list out?
Yes, because I have seen some of you have written the full form also. Can you list down some of the clinical features which you have some idea
Fever.
about it?
Someone said
Okay,
fever.
thank you. I have 1,000 participants, so I want a more response. Cough, fever. Okay, swelling, cough, weakness,
Stomach upset, respiratory
fever,
distress,
okay.
breathing difficulty,
breathing difficulties,
Okay.
shortness of
shortness of
breath,
breath,
stomach pain. Okay.
respiratory.
Yeah, okay.
Thank you so much.
Thank you so much. Okay. So the clinical features here are like, as we have mentioned, yes, it is fever here as in the picture. The first one is fever, and then the second one, it's conjunctivitis, that is red eye, and then rest on back, chest and abdomen, and swelling of hands, and here inflammation of the mouth, lips and throat, and redness and swelling of hands and feet, fatigue, and abdominal pain, vomiting, diarrhea, loss of appetite, or not drinking enough fluids, and enlarged limb glands in the neck, and irritability or abnormal body movement. So these are the clinical features. I hope we understand till here, clinical features. Okay, and then now let's go to the diagnostic criteria. In diagnostic criteria, according to WHO, is all of the following criteria has to be there. That is, child from 0 to 19 years of age with fever for more than 3 days, evidence of COVID-19 and contact with COVID-19, elevated markers of inflammation, that is raised ESR and CRP, etc., and no other obvious bacterial infection. And any two of the following has to be there. There is one is skin finding, that is raised, as we have seen in the clinical features, that raised bilateral or non-purular conjunctivitis or mucocutaneous inflammation signs, that is in mouth, hands, or feet. Hemodynamic instability, that is hypotension or shock, and cardiac dysfunction, so like myocardial dysfunction and pericarditis, valvitis, and in echocardiogram findings and raised BNP, TROP-T, etc. And then evidence of coagulopathy, that is prolonged PT, epididy, and D-dimer, and gastrointestinal dysfunction, and in diarrhea, vomiting, or abdominal pain. So these are the diagnostic criteria. I hope you understand the clinical features and diagnostic criteria, after which we will go to the case statement. Keeping in mind the clinical features and diagnostic criteria, we will see the case study here. The first case we have taken, a 5-year-old child came to casualty with complaint of, we will listen nicely or see in the this one screen, like we will be discussing on this, okay? Then it's a 5-year-old child with fever, with rest 1 week, abdominal pain 5 days, irritability 2 days, history of both father and mother COVID-19 affected, and on examination, vital sign is heart rate 140 per minute, respiration 46, and pulse is feeble, temperature is febrile, BP 80/40, and RBS 216, and head to toe examination, rest is present in upper limb, lower limb, and chest, and mouth ulcer is present. So keeping in mind all the clinical features and the diagnostic criteria, that can you please list out whether it is fulfill the diagnostic criteria for the MISC or not? Like, if any finding, like you can write in the check box. What are the findings? You can write even that also. What are the findings that you made here with this case? You can write that. Your findings.
Whatever
Yeah,
you
it is.
have
If
experienced,
it is
you can
yes, what are
write.
the findings that you can make out from this case? Okay, fever with chase. Yeah, also.
Answer rash.
Rest is there.
Okay. Fever rash. Fever. Rash. Ulcer. Fever. I think. Hypotension. Virtual rash. Okay. Tachycardia.
Tachycardia, yes, it's there. Mouth ulcer, it's there.
Yes. Yes. Diarrhea.
Mother and father exposed to COVID-19. Yes.
Thank you.
Very good. Right?
Yeah. Thank you so much for your participation here. Okay, now we will see here. We said like 5 years old child. Okay, 5-year-old child falls within 0 to 19 years. That is the first thing. And then the second one, you can see here, fever is more than 3 days. Okay, and then the next one is abdominal pain. Okay, is there? So GI involvement is there, and irritability is there. The child is sick, and then both father and mother were COVID affected. That means the child is post COVID exposed. And then here, seeing the vital sign, you can see the tachycardia, tachypnea, BP, though it falls in the normal range, and then RBS 216. Okay, so you can see here, no, BP is not normal, sorry. It is 80/40, it is hypotension, sorry. So, and hypotension is there, and in head to toe examination, you can see the skin involvement. So here, so we have already asked whether it fulfills the diagnostic criteria for MAC. Many of us have said yes already, so we will not ask for that. So here we can say, yes, it is query MISC. If we suspect MISC here, we will go to the Tier 1 investigation along with the supportive treatment that will be given as advised by the doctor on duty. Okay, so this is the first case. I hope you understand with the first case. Now let's go to the second case. Okay, in the second case, we take here 4 years old child came with complaints of fever for 2 days, then febrile, and then loose stool. Here we can see it is 5 episodes, but watery, irritability, and no history of confirmed lab test for COVID-19. Vital sign, heart rate 150 per minute, respiration is more than 50, pulse is feeble, temperature febrile, BP 80/50, and RBS is 120. Okay. So what are, like the way we do in the first case, what are our findings here? You can please write in the chat box here. Our findings.
Is it MISC or not?
Whether it fulfills the MISC criteria, diagnostic criteria or not, or
You can write a yes or no.
yes or no.
With this child, no? Whether do you think that this child is suffering from MIC?
Yes or no.
Okay, yes or no. Okay, many of you, thank you. Many of you are mentioning no, no, yes, no,
Thank you.
no, no. Okay, yes. Okay. 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 Okay.
I think most
Thank you for
most of
your
them are
yes.
right only.
Most of you have mentioned no.
Thank you so much. Yeah. Now let's see. Okay, the age here we gave is 4 years, so it is within 0 to 19 years, of course. But like here we can see the fever is. It is to hang after that. Okay. Here fever is less than 3 days. Okay, and then but GI involvement is there, but there is no history of COVID exposure. There is tachycardia and like this tachypnea, but BP is normal as we gave in the down note. You can see that, so we can say the patient is AZE, and we can continue the supportive treatment as advised by the doctor, but at the same time, we have to see for the evolving symptoms of MISC, whether the fever continued after 2 days, it lapses or not, or else whether the loose stool stops or whether it continues or not. All these things we have to see for the evolving features of MISC here, and then we have to see, monitor the vital signs, okay, and then we have to see the in any restless development of recess in the child or not. Those things, evolving features of this one, MIS-C has to be checked here also. And if it is so, then we can go with the tier 1 test and then we can proceed as advised. Otherwise, we can take it as an AZE here. And in the note, you can see the normal BP here. Normal BP is
Expand
systolic.
AGE, no? Expand AGE, what AGE is.
Yeah, AZ, acute gastroenteritis.
Diarrhea
Okay,
only,
it's a
no?
diarrhea, okay, AZE. And then here, normal BP, that is systolic, is 90 plus ACE into 2. That is, here we can see that our child is 4 years. That means, no, we will not go with this. We will go with the hypotension cutoff. And hypotension cutoff systolic is 70 plus ACE into 2. Our child is 4 years, so 70 plus 4 into 2 is 78. So here the BP is 80/50. So we can take it as a normal. Okay. And then now let's come to the stepwise investigation in a patient with MIS-C according to the Ministry of Health and Family Welfare, Government of India. Okay, here if the fever is more than 3 days and epidemiologically linked to SARS-CoV-2, and if clinical features suggestive of MIS-C is MIS-C, if it is not there, if it is no, evaluate for alternate diagnosis and monitor for evolving features of MIS-C.
Like your case 2, no?
Yeah, like the case 2 that we have discussed. Okay, there these things were not, it was not the case 2, there was no suggestive of MIS-C, but we have to monitor for evolving features of MIS-C, and if it is there, then we can go to the tier 2 evaluation, workup for common tropical infection, and then if it fulfills, till then we'll keep okay. And then here, if the features are there, if it is yes, then we have to see whether it is there's shock or shock is there or life-threatening manifestation are present or not. If it is yes, then simultaneous tier 1 and tier 2 workup for common tropical infection has to be there. And then after that, we have to see whether it fulfills the diagnostic criteria for MIS-C or not. If it is yes, then any of these are present or not, there is cardiac dysfunction or shock or coronary involvement is present or not, or multi-organ dysfunction syndrome is there or not, life-threatening conditions are present or not. If it is yes, may start treatment while completing evaluation for tropical infection, and if it is no, rule out tropical infection first. And if here if it doesn't fulfill the diagnostic criteria for MIS-C, then you can evaluate for alternate diagnosis.
Good, again.
Alternate diagnosis and monitor for evolving features of MIS-C. Okay, and the same thing here. If shock and life-threatening manifestation are not present, if it is no, then we can go for tier 1 evaluation. And then if tier 1 evaluation is positive, then we can go to the tier 2 evaluation and work up for common tropical infection, and will follow as we have mentioned earlier here. Okay, so these are the stepwise investigation in a patient with MIS-C. And now we will be, in the next slide, we will be explaining what is tier 1 evaluation and tier 2 evaluation. Okay. Here, investigation in MIS-C depends upon severity of the diseases. In tier 1 test, it consists of CBC, CRP, ESR, LFT, KFT, blood sugar, blood gas, and SARS-CoV-2 serology, RT-PCR. And these are the tier 1. And in tier 2, there's electrocardiogram, echocardiogram, BNP, troponin T, ferritin, LDH, IL-6, PT, APTT, T-dimer, and fibrinogen. So these are tier 1 tests and tier 2 tests which we have mentioned in the previous slide. The next, and we take positive tier 1 when both of these are present. That is, here in 1, either CRP or ESR is raised in number 1, and 2, at least one of these, that is lymphocytes, platelets, sodium, neutrophil, and albumin are low. At least one of these are low, and isolated increased COVID-19 antibodies are not synonymous with MIS-C. For diagnosis of MIS-C, it is mandatory to rule out common tropical infections, including malaria, dengue, enteric fever, rickettsial illness, scrub typhus, etc. Now let us come to the management of MIS-C. First, let us see the flow chart. Okay, according to the IAP standard treatment guidelines, it is grouped into 4 category here. Okay, management of MIS-C. First one is without shock. In without shock, IV methylprednisolone 1 to 2 mg per kg per day is given. Okay, here methylprednisolone we have to redilute it in NS and like 50 ml or 100 ml as advised by the doctor and keep over 30 to 1 hours infusion. That's how we give IV methylprednisolone. And then if it is with shock or multi-organ dysfunction syndrome, okay? IVIG 2 gram per kg and then IV methylprednisolone 2 mg per kg per day are given. IVIG is given as usually doctor write the instruction on how to give the IVIG first, like 0.5 to 1 mg per kg, okay, per kg is given within first half an hour. And we will observe for any changes in the vital signs, arrests, or any complication, reaction on that. And if there is no reaction, then we will, after half an hour, we will increase the rate to 3 to every half an hour, 3 to 6 mg per kg, we can increase it. And it is usually given 12 to 16 hours, okay? Then IV methylprednisolone, I have already explained in the results. And then here, with Kawasaki phenotype, IVIG 2 gram per kg can be given, as explained, and IV methylprednisolone 2 mg per kg per day, and aspirin 3 to 5 mg per kg per day are given, okay? If symptom persists for more than 48 hours or disease progressing despite above these treatments, consider refractory disease here, and then pulse IV methylprednisolone 10 to 30 mg per kg per day, maximum 1 gram, and or anakinra more than 4 mg per kg per day IV or subcutaneous after expert consultation can be given. So these are the flow state management. Now we will come to the next slide. We will be explaining the next slide. And then here in the MIAC without shock, as we've seen in the flow chart, any MIAC without shock. Any child who fulfills the WHO criteria for MIAC and stable without any features of shock, okay? Any features of shock, then I think we'll be explaining the shock down here. And here, the second one is MIAC with shock or multiple organ dysfunction syndrome, okay, MODS, that any child who fulfills the WHO criteria for MISI and having features of shock in the form of tachycardia, as we have seen in the first case, okay, hypotension requiring fluid bolus more equal to 30 ml per kg or inotropic support. Here, the multi-organ dysfunction syndrome is any child who fulfills the WHO criteria for MISI and has 2 or more organ involvement, that is respiratory, cardiac, central nervous system, renal, and liver. And MIAC with Kawasaki phenotype here, children who meet complete or incomplete Kawasaki disease criteria as defined by the American Heart Association. Kawasaki diagnosis is here, number 1, fever lasting for more than 5 days. And at least 4 of the following 5 clinical criteria has to be there. Number 1 is polymorphous stress excluding bullous or vesicular eruptions, conjunctival infection, oropharyngeal mucous membrane changes, extremity changes, and lymphadenopathy. Out of these 5, at least 4 has to be there, along with fever for more than 5 days in Kawasaki diagnosis. And MISI with refractory disease. Any child who fulfills the WHO criteria for MISI and has not responded to first tier therapy, that is IVIG and low-dose steroids, after 48 hours are considered as MISI with refractory disease.
How many of them have heard of Kawasaki phenotype or disease?
Yeah.
Anyone?
Yeah,
Did
you can
anyone ask
it.
about that?
Yeah. How many of us has come across the Kawasaki disease or heard about the Kawasaki disease? Yes or no? You can write in the chat box.
Yeah.
Yes.
Let's
Not heard.
Okay. Not heard. No. Yes.
Yes.
Pauna have heard. No.
A few yes.
Yeah.
Yeah. Few. Those who have heard, can you tell a little bit about if you want to say?
Yeah,
Or
you can
even
write
if
in
you
chat
want
box.
to write in chat box also, you can write down. Okay, many of you have mentioning no. Only few have mentioned yes. Okay, no.
You go back to the clinical features, no? We'll see.
Yeah.
That is just it.
Okay,
Some
yes.
features.
We saw only few yes. Okay, heard about it, but have not come across a patients with Kawasaki.
Related to
Related to
renal
lymph node
dysfunction.
dysfunctions. Okay.
But in this one, we see also there's
Yes,
not
fever with the rash,
Yes, yes.
Okay.
stomach inflammation.
cherry
patient-
lips. Okay,
Yes,
in Missy also there's cherry red lips
Kawasaki
are
also
there.
has
Kawasaki also
strawberry
lips
tongue.
are
strawberry
there.
tongue. Yeah,
Cherry
they have both.
redness in the eyes also.
Yeah,
Cherry lips.
yeah,
Okay,
conjunctivitis.
strawberry,
Autoimmunity.
autoimmunity, liver chemicals. Okay. Thank you so much.
Okay, thank you. And yes, some of us we have come across. Okay, and then if you see they're almost all same. Okay, but like in Missy, we saw in the in diagnostic criteria we have seen that fever for more than 3 days. Okay, 3 days in Missy. That is that I think difference we have seen here in Kawasaki lasting for 5 or more days. This is the only difference. Otherwise, almost all the this one are clinical features are almost same. So that's it. It is like even Missy is also known as Kawasaki-like disease. Okay, it's Kawasaki-like disease. So it is also known as they are similar. Okay, even the management also we have seen
Similar.
Kawasaki phenotype. The treatment also, ma'am will explain better later. But it is almost same.
What you mentioned there.
Yeah. Okay. Thank you. Thank you for the participation. Now let's go to the next one. And if patients are serious or life-threatening, or if they are critical, then we have to stabilize the patient, airway stabilization and adequate perfusion, treat the organ dysfunction and prevent further progression, control of systemic inflammation, and close monitoring for disease progression and long-term follow-up for complication. Here we can see the mnemonics for this one. A is airway stabilization, adequate perfusion. B, beware of organ dysfunction. And C, control systemic inflammation and close monitoring. For D is disease progression. Okay. Now let's first come to airway stabilization and adequate perfusion. Most of the children with MIS-C, 70% of the children needs an ICU admission. Okay, here children with MIS-C are preferably admitted in ICU for those who are very sick and are usually kept in SCU for close monitoring. And if they are sick, then airway stabilization, prop up head neck midline, neck lightly extended, and O2 supplementation if required, and mechanical ventilation when indicated. And then coming to adequate perfusion, there might be cardiogenic shock due to heart involvement. There might be tachycardia and hypotension, okay, and vasodilatory shock due to presence of inflammation. Here, IV fluid bolus with NS can give 10 to 20 ml per kg over 30 minutes to 60 minutes, okay. And then we can start with epinephrine if cardiogenic shock is present, and norepinephrine if vasodilatory shock is present, and vasopressor if refractory shocks are present, as advised by the on-duty doctors. Okay. And here, next point is treat organ dysfunction and further prevent further progression. Yeah, broad spectrum antibiotic coverage has to be done after obtaining the blood culture test, and antibiotic has to be initiated within the first hour of admission. And then we have to maintain BP according to age, which we have shown in the previous slides, the normal systolic BP. And it will help us by monitoring that and recording that. It will help us to prevent organ dysfunction and maintain good organ perfusion. And third point, we have written judicious use of fluid, be it IV or oral, which will help us to prevent fluid overload. And we have to do the strict intake output monitoring here. And control of systemic inflammation by using the right immunosuppression. The aim is to reduce tissue inflammation and prevent progression of coronary artery aneurysm or myocardial dysfunction. 3, using IVIG and corticosteroids, as we have mentioned in the management early flowchart. IVIG dose is 2 grams per kg per dose, single dose over 8 to 12 hours or 12 to 24 hours. Second dose required according to child as advised by the child status as advised by the on-duty doctor. And number B, methylprednisolone administered simultaneously with IVIG at low dose of 2 mg per kg per day and pulse dose of 10 to 30 mg per kg, maximum up to 1 gram. And slowly transition to oral prednisolone, tapered over 2 to 3 weeks with clinical and CRP monitoring. And now for anakinra, child with refractory anakinra is given in a child with refractory disease despite glucocorticoids treatment and who are contraindication to steroid. The dose is more than 4 mg per kg per day IV or subcutaneous should be considered after expert consultation, and the infliximab currently not recommended for use in children. These two drugs, anakinra and infliximab, these two drugs as of now we don't use here. Okay.
We have never used.
We have never used
for any
also,
of
but
our
like it is
patients,
recommended, but the fifth one, of course, not recommended for use in children. Maybe in a later part, since the disease itself is a very new, it might come up. Also. Okay. Close monitoring and disease progression. Vigilant clinical monitoring for progression into hemodynamic instability or organ involvement should be done, and the monitoring of inflammatory markers is recommended till patient is stable. ECG and echocardium have to be repeated after 48 hours as per clinician discretion. Subsequent echocardium at 1 to 2 weeks, 4 to 6 weeks, and 1 year if initial echocardiogram is abnormal. If child appears unwell or deteriorates after 24 to 48 hours of treatment, consider expert consultation. And then here, MISC with documented thrombosis or decreased ejection fraction with coronary artery involvement. Here we give enoxaparin 1 mg per kg, that is 0.5 mg per kg per dose, and low dose aspirin 3 to 5 mg per kg per day, maximum up to 80 mg per day. If platelet is more than 80,000 per microliter, and it has to be continued till normal coronary arteries. In patient with aneurysm or risk of thrombosis, it is desirable to continue antiplatelet and anticoagulation. This is about anticoagulation. Okay? And then long-term follow-up for complications here. Mortality rates reported in India, children with MISC from western part of India is 4.3%, and mortality rates reported from developed countries varies between 2 to 4%. And follow-up is highly recommended. Okay? And then here, coronary and artery aneurysm is 25%, cardiac dysfunction 50 to 60%, respiratory failure it's 30%, renal involvement is 12%, CNS 3%, systemic thrombosis 3 to 6%. In conclusion, MISC or MISC, we read it as MISC or MISC. Okay, is a serious and it is uncommon, of course, it is not common condition, but timely diagnosis and treatment, right medical care. If it is done, then patient will recover early. Okay, it's much okay. Okay.
Thank you, sis.
Thank
you for the wonderful sessions. Now I request Rosina ma'am to say a few words.
Okay, I think today's session, like we learned so many new terminologies. No, I hope it does not scare you, but I think it's a good way to sensitize our everyone about the existence of MISC and also learning about what Kawasaki disease is. So many of you have responded with, correct answers of Kawasaki. Once you've seen Kawasaki disease, you'll never forget it for the rest of your life. So similarly, especially in those who are affected with COVID-19 or even exposed, the child does not have to have COVID-19 infection. I mean, many times, most of our MIC cases, the parents don't even know they have COVID-19 infection. So you have to have a high, a suspicion in this case. So when we do the COVID-19 serology, then we found they are positive. So you need to have a high index of suspicion to be able to diagnose MISC or look for, Kawasaki-like illness, and then start treating those cases, and they do recover. Yes. They do recover quite well with early treatment and intervention. Then what else I have about MIC? That's it only, I think, and I hope
if it is recognized early,
if it's recognized early,
is good. But if it is delayed, then with complication, it's very difficult.
If it's recognized early and they reach us early, most of them survive unless they come in a very late stage. That's why early recognition. Probably that's the whole purpose of this class, no?
Yeah.
Early recognition and timely referral or timely treatment is what we need, because it's very serious, because once you have cardiac dysfunction, they go into shock very rapidly. Children will deteriorate and they go into, like decompensated state and multi-organ dysfunction, as we've seen, right? So you'd have hypotension, renal failure, CNS manifestation, so many complications, which even if you treat also, some of them will be irreversible. That's why like early recognition and at least being sensitized to what MISC and other like inflammatory disease like Kawasaki-like illness is important. I think we have seen quite a lot since the post-lockdown. Now we've stopped seeing cases.
We have seen in Piku, I think serious one. I think we have around 7
we have quite
out
a
of
lot.
to die. Some of them, maximum of them recovered.
The ones who died also most probably like, they came very late.
Became very late. It was
yeah,
like
so
with multi-organ failure.
Multi-organ dysfunction. No? So that's why early recognition is important. And I think, I hope this session has benefited.
At least the clinical features and diagnostic criteria, if we can make out that, we can recognize the MIS-C in an early stage, and we can.
And like nurses, like most of the attendants are nurses.
No, all are nurses.
Nurses, okay. Yeah, nurses will play a part in, like early recognition. Like suppose if you're working, about this, maybe like some, you may have doctors who've not heard of it. It's always good to mention that, I say like maybe it's MISC, the patient had COVID, like that suggestion. You can always give your suggestion. Don't just stay, because ultimately we're all working together to save a life. So I hope this will, help.
Sometimes
all,
it
like,
might be missed out from the doctor's side also. That's how sir used to teach us, like, like it might be missed out also. So like when at the bedside, say we have said evolving features of MIS-C, we have mentioned about evolving features of MIS-C. It might not be there, but later it might come. So like since we are constantly at the bedside with the patient, so we have to play a role in finding out early stage of MIS-C.
Especially like the evolution of rashes and all, all that you can mention. The parents will be telling you, like, the child has a rash, or there's a swelling in the leg or hands and all that. So you can always point those out, like during the doctor's rounds. That way the cases will not be missed. If there's any question, I'm more than happy to.
Ma'am is ready to answer all the questions, your queries if you have.
You can write down your yes.
We have already mentioned cardiac dysfunction, 25% cardiac dysfunction. So you have this cardiac involvement, meaning like shock and tachycardia, that is present in more than 50% of the cases. If you go to the last slide, more than 50% of the cases, like your heart rate, that's your increase in heart rate. Tachycardia is the earlier sign of shock, unless there's any other sign of explained causes of raised heart rate, like pain or fever. So if you don't have those, early, like tachycardia is the earlier sign of cardiac dysfunction and shock. And the other 25% we're talking about is like cardiac aneurysm and thrombosis and all. So that's like 25%. It's a bit, it's less, probably less than 25%. Prognosis in comorbid client.
What about the problem in comorbid client?
Comorbid client meaning like if you have other comorbid condition. No, that depends. That will again depend on the early diagnosis. I mean, it depends on what comorbidity you're talking about. Suppose you're having a patient with respiratory disease, or like chronic respiratory, like bronchopulmonary dysplasia who require oxygen, or a compromised lung function. In that case, again, early intervention, probably early mechanical ventilation might, help in that initial phase. What other comorbidities you can think of? So respiratory, then if already underlying cardiac disease, if you have underlying cardiac disease, like underlying cardiac congenital heart problem or other problem, again, recovery will be late in those cases. Again, like for everyone, if you catch them early and you give the treatment, they will recover. But if you have comorbid condition, maybe the time to discharge will be longer. They'll stay in the hospital longer. As with any other comorbid condition, if you're having like a respiratory problem, or you're having a like renal, like a renal disease or heart problem, heart disease and all. If you have all those, your time to discharge will just take a longer time.
I hope you got the answer, Natalya.
Cardiac dysfunction, this one, according to the IAP, we have sorted 50 to 60.
Cardiac dysfunction means I want to need like your
IAP 2022, it's
like
given as 50 to 60.
Very high, like most of your shock, arrhythmias, carditis, all that. No, quite common.
Another question is asked by Diamond. Can this disease affect again
the same child? Not that I'm aware of. I don't think so. I've not heard of it
They have
affected the
not
same
come
child.
Actually,
Yeah.
long-term complication is unknown. Okay, as of now, cannot say like I have
Long-term means aneurysm,
complication.
that's
It's
a cardiac problem only is what we are.
If any
Can
of
MIC leads to
any of
encephalopathy?
the participant, if you have
Mm.
seen any child, no, again, they are suffering twice. You can mention in the chat box so that because during our time, we have not come across
Yeah,
the
not
same child
many.
suffering twice. So
Like it's
if
still a
anybody
new
have-
disease. Yeah, not
yes.
much research has been done. I know enough study to say that this can recur again. Maybe if you have touch wood, if you haven't had the COVID pandemic, then may have again as a as a
But if
result of the
any-
initial infection.
But if you know among you, if any of you have come across such kind of cases, you can mention in the chat box
Mm.
and share your experience with us,
Yes,
also,
yes.
ma'am, if they have.
Then encephalopathy, MIC, yeah, encephalopathy again related to shock. So related to hypoxia, shock. Okay, so if your perfusion is affected, obviously a cardiac will be involved, right? So if your perfusion is affected, if your BP is low, then your brain will also the perfusion to your brain will also be affected. Then it does leads to hypoxic injury and encephalopathy.
I
It
think,
can be, yes,
Vinita,
yes.
you got the answer that you have asked. Does MIC lead
Yes,
to
encephalopathy, yes.
encephalopathy or not?
Like yeah. I
Okay.
think it's clear, no?
I think, Vinita, you got the answer. You can mention in the chat box.
Mhm.
If any one of you want to share your experience with such kind of cases, please, you can write down in the chat box or you can raise your hand. We can give a chance to talk. Okay. I have not seen any. Feedback link and all is, if it's not working, I'll give you in the WhatsApp. Don't worry. If you want to ask any queries related to this topic, you can write down in the chat box. I have not seen. Thank you. Durga sister have also mentioned in the answer. Like Carmila, I think you got the answer. Ma'am, at what percentage does cardiac dysfunction involve? Durga sister has also answered and we have also answered. Okay, I think we have answered.
What will Shishal go back? Is MIC contagious? No. MIC is not contagious. It's an inflammatory response. Means your body is, developing an inflammatory response to the disease. It's not infectious. COVID is contagious, not MIC. Okay, MIC is post-COVID. Okay.
Preventive measures by MIC again.
Or what are preventive measures? Basically, get vaccinated. Okay, that's one way to prevent MIC.
One more is there.
Prognosis, if treated early, very good prognosis. If not treated like any other disease, child will succumb. Okay, we've already mentioned in the slides also that
Diana,
already
I think
talked about,
you got the answer, Diana. Angela, okay, I'll just see the name.
I think we've covered all the
I
questions.
think we
Yeah?
have covered all the questions.
Regarding antibiotics.
Regarding
Yes.
antibiotics, and
Okay.
we start after blood culture.
Sister Amila can answer that. You've said it in your class. Slides.
No, normally what we practice here is this
Yeah.
antibiotic. If it is sick, okay, like we started after blood culture.
We say it's not infectious, but the thing is, one of the criteria, if you remember on the left-hand side of the slide, which Sister Amila had showed, she says that you have to rule out bacterial infection. Okay. Unfortunately, not to rule out bacterial infection, you take your blood culture and it does not come immediately. That culture would take about 5 to 6 days. Okay, in the developed country, it will take about 48 hours. But in our lab, it takes about 5 days for the blood culture to come. Okay, so we cannot wait for that 5 days if there's an underlying infectious pathologies. So we send the blood culture and then we start antibiotics. Okay, because it's difficult to differentiate whether this presentation of MIC is a bacterial infection or actually MISC. Okay, so most of this diagnosis comes later on. No, but once you suspect it, you start treatment, and then later on you can figure out you have to wait for the lab test and all. No, the lab test does not come immediately. All your lab tests, your ESR, CRP, CBC, all of that will take about half a day or so to come. Okay, so you should not wait until then. So start your antibiotics after taking blood culture, and always, especially in sick child, you have to start the antibiotics within 1 hour, as already mentioned in the slides, in which we are practicing here as well.
I've once again shared the feedback link in the chat box and also the WhatsApp link. You can click and join the link.
still have
Okay,
time.
yeah. Ma'am, one question is asked by Juditha, like maybe if the child having fever during IVIG, should we stop or
No,
should
no.
we
The fever could be if the treatment for treatment of you're starting IVIG for MISC or for Kawasaki, you do not stop. Okay, the child will have fever because of the underlying disease, but you have to look for your what do you call reaction to IVIG. You know, like sudden fall in blood pressure, tachycardia, all those new signs. Okay,
Rashes
but
and
fever, rashes, no, but not fever is not any contraindication to stopping IVIG. That's why we start very slowly, you know.
Yeah,
Initially, you start very slowly. Okay, half an hour you start very slowly. Then you see if the child is fine. Then you slowly increase the dose. So you take a long time to finish IVIG.
among the participants, if any one of you have managed the child or helped in managing
How
the
many
child?
have given IVIG? Any
Yeah.
of you have given IVIG? I think some has asked, no?
Yes. Kawasaki should be treated
Yes,
properly.
yes. We all treat all Kawasaki disease promptly. We wait for the 5 days fever after starting antibiotics. If there's no resolution in the after 5 days, we start IVIG immediately.
So the
Ma'am,
damage is
feeling
more,
the
no?
voice also
Yeah.
When the
severe.
damage is at least place before it
Because
goes,
we
before it
fear
progress.
yes we don't want coronary long-term coronary damage, so we start immediately. Not immediately, I mean you have to fulfill the criteria of Kawasaki again,
Explain about
okay,
IVIG.
which was already explained again. So we need to fulfill that criteria. So 5 days fever. I mean, we had a case that looked like Kawasaki but came on day 3, so we had to wait for 2 more days before we started IVIG and the rest of the treatment. Okay,
Ma'am, Iris has asked, like, how prevalent is this condition in
it's
Meghalaya?
prevalent. Why not? It's prevalent. It is there. Okay.
We
Some
have
of them are being treated in the other district hospital also. Some have come to us. It is prevalent. But we don't have a number. I mean, the state government will probably have a number because all MIC diseases are being reported to the state. So they'll have the data. We do not have. We only have the 7 cases that we have treated.
And then they explain about IVIG again, no? Here.
Okay.
I think the dose will be decided by the doctor.
Yeah,
Okay,
the dose is 2
as we
gram.
have-
The dose is 2 gram per kilo.
It's written
Okay.
there. Okay,
Yeah.
but doctor will definitely write there, of course. But when we start, doctor might tell how much ml to give initially. Okay, like, but according to the book that we have gone through, it is 0.5 to 1 mg per kg per body weight. Like, we have to start slowly within half an hour. We have to start in the minimum dose in half an hour, and we have to monitor the vital signs. BP, as Ma'am has said, tachycardia, for tachypnea, for hypotension. We have to monitor all those things in half an hour, and development of any race or restlessness, everything we have to monitor. Okay, and then if nothing happen, if everything hemodynamically stable and like no recess, no complication, then we can gradually increase after half an hour, 3 to 6 mg per kg. We can every half an hour we can increasing. So we can go until like 12 to 16 hours, or like
Sometimes
some
even
12 to 24 hours
also
also
we
it
have
goes.
given.
It depends on the thing. 24 hours also.
And you need to give infusion pumps. Okay, so for those of you
Yeah, it's
using
easy.
infusion pumps, it's easier when you use infusion pumps to give IVIG.
It has to be we have to, it's aseptic technique. Okay, we have to use an aseptic technique, and we have to use a different IV set for that. And if we have a syringe pump, it's base, of course, we will arrange in the syringe pump, and then we can give it. And then if there is no syringe pump, then we can use the micro drip set there. And then there you can set the micro drips according to per minute how much you need to give. So like in half an hour, if you have to give 30 ml, okay, in half an hour you have to give 30 ml in half an hour, then you have to set it as 60 micro drops per minute. Then 30 ml will be over in half an hour. So if you have to give 60 ml in 1 hour, then 60 microdrops per minute. If you set it, then 60 ml will be over in 1 hour. So that's how we manage with microdrops if syringe pump is not there.
Okay. I think you got the answer. I think
Of course, there's a formula for that. Okay,
Yeah.
like giving formula is there. Microdrops, macrodrops. There's a formula, but like in short, how we practice. I'm just telling you that microdrops and ml per hour.
Nowadays, with the use of syringe pump.
Yeah,
Nobody
but the easiest in micro drop is that's how we use. Okay, that the drops that, for example, 30 micro drops per minute. If we give that 30 ml per hour. it relate like that. So like it's easy to remember also in practical. I think many of us, we do that also. Okay, so we do that.
We still have a 10 minutes if you want to ask any more questions or if you want to share your experience.
Yeah.
It's okay. It's not right and wrong. We just want to hear from you, or other participant will also, get to know something from you all. So you can raise your hand or you can write down in the chat box so that we can read it. Thank you. Those who have submitted pre-test, post-test, feedback, everything, those who have submitted, thank you so much.
I hope for many of us, like MISC, as we said in the beginning, it's a very new, okay, for many of us, but today I think we will know. Some pronounce it as MISC, some as MISI, and then the full form is multi-inflammatory system syndrome in children. And in adult, it is MISA. I think A is for adult, and neonates is MISN. Okay, so in children, it is MISC.
Even in neonates,
Neonates, it's there. Neonates
cases have been there.
Yeah. But we don't have case of course, but like it is there. MISN.
Is it condition very severe in a child or is it mild?
Severe
It is
in child.
It is severe. It is severe.
It's severe.
We
It's
can
quite
we have to
okay.
take it as serious.
Serious. It's very serious condition.
condition. Okay, it might be mild, but it progresses very fast into
It is a serious
It
condition.
is serious condition. We take
Okay,
it.
and the severity would be based on whether the shock is present or not. Okay, but it's a serious condition.
Start managing as fast as possible.
Recognizing is the
Yes.
most important thing, no? Like the
Yeah.
symptoms and like
And these
diagnostic.
patients come with both symptom of FIC and Kawasaki.
What? MISC and Kawasaki.
Not that I've seen, or maybe
Elizabeth,
Other places.
we have not.
like I mean, like
experienced it now.
see, like we have no other alternate diagnosis. No, if your criteria for MIC is not fulfilled, okay, and then your criteria for Kawasaki is fulfilled. If your COVID and COVID exposure is negative, right now, if any child comes, like 1 year old or 2 year old who has not had any exposure to COVID-19, or parents have been vaccinated, then has all these features, and then COVID serology is also negative, it could be Kawasaki. Okay.
But treatment is also almost
Yeah,
same,
same
only. Then ma'am, can you explain
Pain,
about that?
MIC, cardiac
Cardiac
dysfunction.
First, I wanted to say OnePlus, please rename your device.
Elevated BNP.
So cardiac dysfunction means it can start from right from tachycardia, your carditis, no? Carditis means like your tachycardia, even changes in the valve, pericarditis, raised cardiac enzymes like your BNP and TROP-T. Then another thing is because of the cardiac dysfunction, your your cardiac output will be affected. Okay, because your cardiac output is affected, it will lead to hypotension and shock. All right. Then that is earlier cardiac dysfunction, and then the late cardiac dysfunction, which is a complication, would be aneurysm, cardiac aneurysm, and your poor ejection fraction. That means your heart is not pumping blood as it's supposed to pump. Okay, so those are your early and late cardiac dysfunction.
I think that's it.
That's it.
Close. Yeah.
I hope it's clear.
Yeah.
I've
Now
tried
we-
to explain it in a very simple
way. And then we have covered all the questions. Now I have not seen any more queries. I have not seen anything. So I think we will close today's sessions. Thank you so much. I will share the pre-test one for the management. It's in the same for the adult.
Adult also they still use IVIG and prednisolone, methylprednisolone. Okay, as for maybe the monoclonal antibodies, infliximab, they can probably use that in adult. Okay, yeah.
Okay. I think thank you so much. So thank you, Sis Emila.